Hello, and welcome back to Dr. Carri's Clinical Corner. Today we're going to talk about prolapse. Prolapse is when your organs inside the pelvis are lower than how they started. And so for what people feel is usually they feel like heaviness or pressure. They generally don't feel pain, but more like pressure in the pelvis, or they feel like something's falling out, or it feels heavy, are usually the words people describe that. And that's a prolapse, or they might see something or feel something in the vagina. Prolapse doesn't happen in men, it happens only in women. And it's when your organs, so here's the pelvis. Let me try to show you. Here's the pelvis. And so sort of our organs kind of all sit in here, and it's like you start to like see something inside the vagina, or you might feel something kind of at the surface, or if it's really severe, you might see it coming out. So prolapse comes in 4 grades. So grade 1 and 2 mean everything is still inside the pelvis. Like you might see something in the vagina, but it's still inside. Grade 3 and 4 means things are coming out. So if they call this like the prolapse chicken. So if we look at the bottom, like grade 1 and 2, it's still there. Grade 3, it's coming out. Grade 4, it's coming out. So that's sort of like an example of prolapse. Your prolapse, like it could be the bladder or the uterus or the rectum. And those are all coming through the vagina. You can have a rectal prolapse that comes through the rectum. It's pretty uncommon, and I guess potentially men could get that too, but what causes a prolapse? Often it comes after pregnancy, a vaginal birth, like a long birth or a difficult birth. For some of my patients, if they have chronic constipation and they're constantly pushing, might have a little bit of prolapse, but I rarely see that as like a significant prolapse. I think it's a little more like hypersensitivity, extra sensitivity. And so sometimes some other words you'll hear or read. A prolapse is called a cystocele with a C, cystocele. A rectal prolapse is called a rectocele, and a uterine prolapse it's uterocele. I never see that word. Or it could be all of those things. So, you know, a couple things about the grades. Most of the time, my clients, I see they have grade 1 or 2. So our organs, so here's an example. This is your uterus and your fallopian tubes and ovaries. Your organs are suspended by ligaments from up above. Same thing like the bladder, it's suspended by ligaments from up above. And so a grade 1 or 2 means these ligaments are a little lax. They've been stretched out and they're like letting things sit a little bit lower in the pelvis. A grade 3 or 4 means one of those ligaments is no longer, I don't think I could do this, is no longer holding on. And we could test for this in the clinic. So I kind of feel, when I feel the pelvic floor muscles, I kind of feel at different parts. Like, is the muscle contracting here? Is it contracting here? Is it contracting here? Is it contracting here? And if it's not contracting at one of those points, then we might think maybe the ligament is torn. Yeah, so the ligaments also attach into the muscles. Everything's really interconnected. We want to think of it as like these nice separate things, but they're really interconnected. And one thing I carry with me that I learned from school is the bladder and the uterus, the ligaments that suspend them are intertwined. So for people that have a hysterectomy, they just take this away. This can affect the bladder. So not only is there like not a space here, but the bladder has less support from up above now. So, a lot of times, like for women that have endometriosis, they're like, let's take out your uterus, which makes no sense because Endometriosis, by definition, is tissue that's similar to the uterine lining, but it's growing outside of the uterus. So why are we taking out an organ that's not the culprit? So there is something called adenomyosis, which is like happens inside the uterus. So in that case, potentially, but endometriosis, like, why are we taking out these organs when the problem is the tissues outside of that are reacting to hormonal changes and stuff? Anyway, side note, back on track. So, a lot of times people are like, I'm going to get a hysterectomy. And like, if you need it medically, absolutely 100% yes. But I think so often I see in women's health, like doctors don't really know what to do for your symptoms. So they're like, let's just take out this organ. You don't need it. You're not going to have any more children, right? But this organ has other functions too. And it helps keep everything in place. It was there for a reason. So anyway, pet peeve of mine. But anyway, so it can be any of these organs. And so we test it in the clinic by looking. So we look, when I have people laying down, like, do I see anything in the vagina that is coming down that shouldn't be there, right? And then I have people stand up and I look when they're standing to see if it looks different, because oftentimes it does. So if it looks similar lying down and standing, great. Like, it's minimal. Hopefully minimal. But for a lot of people, they look fine when they're lying down, and then they stand up and like, whoop, it looks different, right? And I think a lot of times when you go to the doctor, they're not doing it. It takes time. It's awkward. I don't really care about awkward, and most of my patients are like, let's just figure this out, right? If I don't make it awkward, they feel fine about it. Anyway, so we look in both positions to see like what, does it look different? So the majority of my patients have grade 1 or 2. So it's there, but it's not coming out. And grade 1 or 2 can get better. So what does better mean? That's a good question, because without doing surgery, there's no way we can anatomically raise these back up. But I sort of think about it as like, we're making this environment more comfortable for where the organs are now. And then most people don't have symptoms. So at this point in time, we treat symptoms, because surgery is also honestly not that successful. In my lifetime, in my career of almost 20 years, I have seen one patient who had a grade 3, and I felt so bad for her. She was in her 80s. She had had this for a while, and literally it looked like this. Like, oops. It looked like this. Like the whole thing was coming out, and she's like, I can't sit. I'm like, of course you can't sit. That's uncomfortable. When she lays down, it goes back in. When she sits, comes back out. Her bladder. And bladders are squishy. So another question I get from people is like, is my partner going to feel this with sex? I'm like, no, because organs are squishy. They're even squishier than this jelly thing. They're very soft and like they just move. So if you're having penetrative sex with someone who has a penis, the penis is just going to move it out of the way. There's certain positions that can be better or more comfortable for the person with the prolapse, but honestly, I don't think partners notice because it just moves out of the way. Okay, so someone asked me, like, what exercises do I do for prolapse? And she said, like, I'm doing a lot of Kegels, but it doesn't get better. I would say, honestly, the majority of my patients who come in with prolapse, I do all the normal. Every time someone comes in, I do a pelvic floor test. We test for tightness, we test for strength, all of the things. We do the same test on everyone. And the majority of my patients with prolapse don't have weak pelvic floor muscles, but they have tight pelvic floor muscles. So it seems counterintuitive. So for a long time, the theory was we're going to strengthen the pelvic floor to hold up the organs. But the organs are not attached to the pelvic floor. So it doesn't actually make sense to make this tighter when these are coming down, right? Then we're just like creating more pressure, more force. If we need to strengthen the pelvic floor, then yes, we do. But more times than not, my patients, they have tightness. And I think of it sort of like this. This is my way of explaining it. If these are tight and these organs are coming down, we need to create more space for the organs. So we need less tightness here so that these organs can be comfortable. And so if Kegels aren't working for you, stop doing them. If you could see a pelvic floor therapist, do that. Because a lot of times this will help to be seen in person. But I'll tell you the other thing, a lot of my patients who are pregnant and have prolapse, general strength training helps them. Strength train your hips, your legs, your butt, all the muscles that surround the pelvis. I talk about this in every freaking video, I feel like. The muscles that surround the pelvis do so much more than just these little pelvic floor muscles. So I've had a lot of patients during pregnancy who can't do some of the other things, right? As far as like treatment for the pelvic floor, like obviously they can't get surgery and they just have to like make it through their pregnancy, but strength training helps them. So lots of leg strengthening, bridges, clamshells, squats, side leg lifts and sideways walking and backwards walking and lunges, like any of that feels comfortable will help support you. Also for a lot of my patients that have a lot of symptoms, so kind of like all day gravity is pushing down on this, right? So a lot of times what can help is take some time in the afternoon to lay down. And if you can lay down and put your feet up on something, even better. So that's why a lot of times people feel worse in the afternoon or evening. It's just gravity all day is pushing these down and down and down. And so if you can take a break, then gravity's not pushing down on the muscles. If you can put your feet up or your hips up, even better. So there are also a bunch of like different support shorts and underwear and garments and belts and things. I'll link some in the notes. But there's a ton of those, and those often help my patients too. So there's sort of limited options in pregnancy. So a lot of my patients like these shorts that come from Australia. Australians are great at physiotherapy. They're called SRC shorts, and they make leggings. But those kind of give you support from the outside, kind of like helps hold everything in. That helps a lot. So some of my patients, they'll just wear like regular leggings, or bike shorts, like that will help them. And if they need more, then they get the special ones. There's also this underwear brand that only makes postpartum. It's called Hem Support Wear, made by a woman who just was looking for the right thing. There's a couple other things. There's something called the pelvic bra, and there is something called the PF something. It's by a company called It's You Babe. So there's a ton of different options for external support, and that helps my patients a lot too. And then if you're not pregnant, you can see your doctor, or some places physical therapists do this. There's something called pessaries. So it's like an internal support. And usually you start out with what's called a ring pessary, and it sort of like supports the organs from the inside, and sort of helps them. And then there's, the ring pessary is like the baseline model, but there's like a whole bunch different ones you could try. There's a cube pessary if you need more support. So that's another option I tell people is like, maybe you need that for a time and maybe not forever, but maybe. Another thing I tell people is ask your doctor if you need vaginal estrogen cream or a suppository, because often, pregnancy, postpartum, postmenopause, our vaginal tissues have estrogen. We're learning everything in our body has estrogen receptors, even our brain. Some fascinating research coming out now. But the vaginal tissues, the external, like the skin, the labia, the vulva, by definition, has estrogen receptors in it. And when we lack estrogen, which is pregnancy, postpartum, postmenopause, estrogen is lower at those times in our life. These tissues can become thin and dry, but if we get some estrogen cream in there and it helps thicken the tissues, that can give you more support. So sort of like we're hitting this from a bunch of different perspectives. It's not just about Kegels, which is what I preach day and night. Kegels are maybe one part of the answer, but we want to give more support from the outside, so thicker tissue support, vaginal estrogen, supportive underwear, supportive garments, more support from the outside. Strengthening the hips, the legs, more support from the outside. We don't always need to tighten up these muscles. Maybe these muscles need to relax a little more space on the inside. That's what we do for Prolapse. So I hope that helps. Leave your questions in the comments and I will try to get back to them, and I'll make more videos if I need. But that's sort of an overview of what Prolapse is and what you can do about it. And majority of people, it gets better. And there's a lot of things you can do besides just Kegels. I will frickin' die on this hill that Kegels are not the only thing to do. And I would say I don't have a Prolapse specific exercise program, but I do have an exercise video for postpartum return to exercise. That's what it's called. And those exercises are what I do with my pregnant moms and my new postpartum moms. And a lot of my moms that have, or women, not necessarily moms, who have Prolapse is those exercises. So if you want an exercise program, go buy that video on my website and then do those exercises. It really often doesn't have to be like intense. And if you want to do intense exercise, you can. You got to build up to it. You got to do all these things. You have to have strong legs, strong hips, and you got to work on the other things. And then you got to build up your tolerance for more high-level exercise if that's your goal. So, you know, in some of my patients over time, they just need their pessary for running, CrossFit, whatever, and they don't need it for everyday life. So, you know, a pessary is not necessarily forever, and there's a lot of things we could do. So see a pelvic floor therapist, make a virtual appointment. I can talk through these things with you. There are a lot of things you can do. You do not have to suffer. If it's grade 3 or 4, you need surgery to reverse that. But grades 1 and 2 generally get better with non-surgical stuff. And even if you need surgery, I would recommend working with a pelvic floor therapist because these surgeries have a high failure rate. And as a physical therapist, we think it's because there's either bad habits, like maybe you're straining a lot when you poop, so you're putting more downward pressure on it, right? Or maybe you have a lot of tightness and there's not enough space in there. Or maybe you're uncoordinated, you're putting pressure, like you're lifting heavy weights and holding your breath, right? All these things you can work on with a physical therapist to optimize how these muscles work and how this area works together. Whereas surgery, they just go like sew up the ligaments, tighten them, raise them, send you on your way. But if you have poor habits, of course the surgery is going to fail over time. So some people need surgery, but I would say there's a lot of things you can do before then or in conjunction with surgery to have a better long-term outcome. All right, enough of my soapbox. I'll see you in the next video.